just a recap. It talks about some notes as far as technique. It talks about when you would follow up and do a film, if you use some kind of tubing. And then it gets into the physiology and the function of the respiratory system. Hopefully you're familiar with that by now, since you've been in the program for a while. How do you guys feel about chest anatomy? Good? Okay. So what do you need on a chest x-ray? What do you need on an AP or a PA chest x-ray for it to be a good image?
Your lungs.
Oh, nice. Good. At least 3 ribs superior to the clavicle would be a good angulation for an AP. Okay. How many ribs for a good inspiration? Good. 10 ribs to be visible. That's why we do double inspiration, because the diaphragm moves down. We can visualize more lungs when we breathe in deeply, get that full tidal volume. What else do we need to know? Obviously, we can see the heart, the lateral borders of each lung, centered if we can be. How about rotation? How do we tell if a chest x-ray is rotated?
At the spine and the trachea.
Spine and trachea. Okay, spine and the trachea. All right, so the terminology that a book uses, or one of these books, I don't remember if it's Bontrager or the other one that you guys probably don't have. The terminology or wording is the distance between the sternoclavicular joints should be equal on each side. Okay? So the sternoclavicular joints. So right here, where your clavicles meet your sternum, should be equal distance between the two. I like the spine and the trachea. That's pretty centered though. I mean, that's a kind of makeshift way to do it. But definitely want to make sure. The other way that you can tell if you have rotation is the widening or the elongation of the lungs. Let me give you an example. Go to page 98, 99 in your bond training. 98, 99. I have this one, this blue one. Which one do you have? Green. Okay.
Should be around the same stuff.
All right, well, the new one is the gold one.
Oh, this.
I'm looking at the obliques, the chest obliques. So the page before the posterior obliques.
Page 100.
Okay. Page 100 in the green book.
You don't mind.
All right, so let's talk about this. Without reading on the documentation and it telling you what the actual position is, you should be able to figure out what side the patient is rotated in, depending on if they're in a PA or an AP projection. Can you? Does this seem familiar or no? Don't know how to do this at all? Yes. Okay, so write it down if you don't know it. AOs are opposite. AOs are opposite. And POs are same side. So what the heck are we talking about? We're talking about lung elongation. So on the first one, it's an LAO, figure 276, LAO. So AOs are opposite. So the right lung is wider or longer than the left lung. Everybody tracking?
Yeah.
Second picture, it should be an RAO. If it's an AO, it's opposite. So we should have a left lung elongation or widening. Don't think elongation length, think widening. So when they use the term elongation, it always says widening in parentheses. So the wider lung.
Could you repeat that, Ms. Ford?
Sure. So the RAO, we should have an AO, so it's opposite lung. That should be elongated or widened. So we're looking at the length, the width of the lung, not the length of the lung. So how wide the lung is actually portraying or being projected onto the image. So since we know that this is an RAO, the opposite lung is elongated on the second image. The left lung is elongated. So that's how we would know what position or how to rotate the patient back. You shouldn't necessarily see this much elongation in the lungs, especially if you're doing a PA or an AP. These are specific to obliques. You can see this is 45, 45, 60, or 60. So your image may not look this bad, but you could definitely look at the sternoclavicular joints. Does everybody know how to look at the sternoclavicular joints always to see rotation? If you don't, raise your hand, let me show you in your book. And I'll point to it. All right. And once you get it, it will be easier. So this one is. Yep. So, this is what I picture my yeah, so these ones are normally esophagrams. But to draw a conditioning where, say you have somebody scared or you think that they're rotating one way, the way that you can see these fixes is by the widening of your body and the opening of your shield. This one is really easy. So this space right here is how it contracts. This one is more like what you're actually doing. But here's the opening here. So this is the outside. While this one is a little more. Alright, and since it's an A, this is side is elongated, and the opposite cervical is so audio, very here, very, very. This one's easy to see as well, audio 45, the right one she is wider. There's the register,
I do have a question. So I'm good on chest x-rays, but it's just like when you go up to an inpatient room and there's like line placement and so she says something. There's like two.
We're gonna talk about.
Okay. So I was like, oh yeah, it's above the vagina.
She said
So you don't necessarily need to know make sure you have everything safe. And it's a thick line, you're out of nurse
Or even like inchy tubes go down further, so like it's not, like this would cut it, but like it's like
right, you're saying if you have an itchy tube, you have a long shaft.
Right.
But then if you break it off, like technically it's a long chest.
So if you have it right now, right? And because they don't want to. So they don't want to repeat.
It's like the And then they'll literally just take it.
Oh, okay.
Yeah, so
That's
what
what I
they
was
want is to make sure.
Get everything that you need for a chest X-ray, but then it's like, the stomach's not for the legs.
Yeah.
But close, you know, in the chest. Just in a situation that they need to, you definitely.
Because like for some people, it's not possible. And that's when I'm like, another image.
Right, so it would kind of be side up here. So if you take a lower chest X-ray, no, you don't need another one. That's why they do it. If they should hand me or an upright abdomen, it would need another one. Yeah.
Can you, for the, you talk about the rotation?
Rotation, yeah. All right, so we're looking at, let me go in the back of the book. All right, so this is something that you would probably see clinically or have 15-23 rotation. Think about it for positioning somebody where they're sneezing and they sneeze, but you're not sure which way they sneeze. Or maybe they're just kind of stand crooked, but you can't really tell. Maybe like this or like this. To fix those small positioning errors, you can look at your image. If it's an AO, you can be an AO if you're taking a posterior, so a PA, our patient will be positioned like this. If it's an RAO, if they're rotated to the right side more, the opposite line is going to be longer. So RAO, we're looking for the left elongation, so the left widening. So this one's just a little bit wider than this one because of the minimal rotations. As you rotate them more, it gets wider, right? Another thing you can look at is the sternoclavicular joint. It pairs with the same line that is elongated. So whichever one is wider, the sternoclavicular joint is going to appear open. Now we're not physically breaking it or moving it, but because of the projection of the rotation of the body, it appears open. So this right here is the actual opening. So where the clavicle ends, this is the sternum. See how there's a space right here? It appears open. So you see it? Here's an easier one up here because it's more rotation. So here's the end of the clavicle, right? You see it? And then there's a space here before the sternum. So this would be the open sternoclavicular joint, the widened or elongated long LAO position. This one kind of just superimposes it. It appears closed. So that's how you can tell your positioning errors. Again, open on this side, wider lung on the left. It's an RAO. Get it? Makes sense? Okay.
You also said AO's opposite.
AOs are opposite.
And PO.
POs are the same. So if you're shooting AP and you're rotated like this, RPO, it's going to be the same side. It's going to be widened or elongated. So this way.
Explain how.
How?
I understand the other way, but the P, I just
Why does it
know
change?
it, but I don't understand how.
How what? How?
So when you do the
how it elongates?
Which one is elongated?
No, like how you do the RPO, I know it elongates the right one, but I get a little confused because when you do the LAO, it elongates the right one.
So yes, AOs and POs are opposite, so from each other. So if we're doing a PA and we're like this, so you have to kind of associate yourself with thinking how the beam is going to enter into the body.
Yeah, like I understand how it enters the A, but not the P.
Not the P, okay, so not like this. for
Yeah,
AP.
that way I don't understand.
Okay, so we're still gonna be centered here, and think about it, this side is gonna be closer, widened. This side's further away, so it's gonna appear shorter and skinny. Think about my lungs, how you're looking at me right now. This
Yeah.
side is wider, this side is thinner,
Okay.
right?
I think,
Same
okay.
thing over here. When I turn, this is my thinner side, my shorter lung, this one's gonna appear longer and wider.
Okay.
Also, the clavicle placement, if you actually look at me, this one's going to be right over my spine, where this one's going to be free.
Oh, okay.
Same thing here, superimposed, free.
Okay.
Good.
Yes.
Makes sense?
Thank you.
All right, I did want to clarify that just in case you didn't know that. That's kind of an easy way to correct positioning errors. Remember, AOs are opposite, POs are same sides. What else do we want to talk about with chest X-ray? Do you guys have any questions before we get into the pathology and the tubes, internal devices? why do we need to take a chest x-ray erect? Why is it best? Air fluid level, okay, what is an air fluid level?
Like pneumos.
Okay. Pneumo what?
Thorax.
No.
For air.
No, because a pneumothorax is a collapsed lung, so all you're looking for there is a absence of lung markings.
Oh, it's called pneumoperitoneum, right?
Pneumoperitoneum or fluid specifically, so pleural effusion or pneumonia, yep, good. But what is specifically an air fluid level? What is that?
You want to see, don't they see the stomach air rise?
Air rising, getting closer. All right, so if we're looking for fluid, an air fluid level is going to appear where? In the lungs. Where? Specifically?
Fluid would be at the bottom.
Bottom, getting closer. Costophrenic angle. Costophrenic angle. Okay? Those bottom angulation, the lateral border of the lungs, it should look like this if it's clear, right? It should be nice and clear, and you should see black area in it because it's filled with air. If this area is containing fluid, it will be cloudy or white or softened. It won't be sharp like this. So if we see fluid in the lungs, when we get the person up and stand them up, the fluid will go to the most inferior portion of the lungs, which is the costophrenic angle. So you'll see it right here demonstrated. Okay, that is an air fluid level. It distinguishes the difference between the fluid in the lungs and the air. So what happens if we lay the person back or they're not able to sit up? The fluid goes just to the back of the lungs. Gravity doesn't help us. So then it's considered non-diagnostic. So why are we even taking the image? Maybe for something else. If it's something specific to the heart, like cardiomegaly, I could see that. But if it's some kind of lung disorder, especially when you're working with pediatrics, very important to always stand your patient up or sit them up to achieve an air fluid level. Remember, all we're looking for is fluid or some kind of inflammation within the costophrenic angle. So that's where fluid is going to appear. Are we good? Feeling good? All right, so what can we do instead of standing the patient up to achieve an air fluid level? How can we position the patient to achieve this if they can't stand?
Sit them up in the stretcher.
Okay, what if they can't stand? Decubitus. If they can't stand or they can't move forward, we can always roll them over to a decubitus, right? Anybody done one?
Yeah.
No, yes. Pain in the butt. Not fun. Not fun exams. At least I don't think so. Especially portably, if you can think about all the ways you're kind of manipulating the body, trying to get somebody up who can't move or isn't able to stand or sit up, and you're trying to log roll them to the side to achieve an air fluid level. All right, specifics. Let's talk about specifics with decubitus. What if we want to visualize fluid? Because I don't think you're gonna know this one. I'm just gonna explain it to you. Let me get a table. Maybe you will though.
Like the side down.
Yes. Yep, side up, side down. All right. So to achieve the air fluid level, if the person is able to stand or sit, we can always make the patient erect and the fluid is gonna fall. I just wanna make sure this is kind of secure before I sit on it. We make sure the fluid is going to fall down to the costophrenic angles. If our patient's not able to sit up like this, we can always do a decubitus. So if we wanna see fluid in our left lung, fluid in the left lung demonstrated specifically, we would perform a left lateral decubitus. So just like this. Left lateral decubitus for fluid in the left lung. So fluid is side down. Why? Think about gravity. Where is the fluid gonna go in my lung? It's gonna go over here, right? So really important that you get this portion in the image, right? So downside, very effective for fluid. However, in this same position, I can demonstrate something of a quality in my lung for air, because air rises. So air is upside. So if I was looking for some kind of pneumothorax, I would see it in my right lung if I had a collapsed lung, my right side. Left lateral decubitus. So fluid down, air up. Opposite, if the doctor wants to visualize some kind of pneumonia or pleural effusion in my right lung specifically, I would do a right lateral decubus because the fluid again is gonna fall, right? So I'll be able to demonstrate it here. If I am concerned about a pneumothorax in my left lung, this would also be appropriate. So air up, fluid down, okay? Air up, fluid down. So that's how we can visualize that. Doesn't matter if it's AP or PA, whichever way you wanna do it. Anybody seen a ventral or a dorsal decubitus done? Yeah, no? All right, so they're kind of phasing out. I only did a couple in my entire career in radiology, but they're also not very fun, but you guys know how to position for them, right? Anybody know what it looks like specifically? So a ventral or a dorsal. So dorsal on your back and the beam is horizontal, so coming through right here to exit here. Ventral would be prone, so you would flip me over. It's for purpose in specific pathology that we don't get into normally, and CTs usually replace this, so that's why we don't talk about it a lot. All right, so we're good on that. All right, SID for chest x-ray. Good. How about orientation of the IR? Crosswise or lengthwise or portrait, depends on your body habit, is good. How about beam angulation? No angle, good, unless we're doing a what? Portable. What's the angle for an AP? I think it's 5 to 7. Let me check. Page 94 in your blue book, so somewhere around there, I'm looking at AP projection of the chest, supine or semi-erect, 5 degrees caudal to prevent the clavicles from obscuring apices. So how I want you to picture this, if we were performing a PA and we're turned to the IR, when we rotate the shoulders in like this, it removes the scapula, right? That's the purpose. We roll the shoulders forward so that we're able to get a clear view of the chest and the lungs. When we do that, it pushes the clavicles down. So that's why we stay perpendicular when we do a PA. However, when we're semi-erect and we have an AP, we need about a 5-degree angle. I think the new book says 5 to 7 to be precise. If you want to jot that down, you can. So 5 to 7 degrees caudal to make sure that your clavicles are projected lower than the apices of the lungs. So we want to see this area here. What can we do specifically if we want to see pathology demonstrated in the apices? Lordotic, good. Lordotic, very good. So you guys are recalling some information finally, good. All right, lordotic, so we can either choose to rotate the patient, the park position, or we can do an angle with an axillary to the beam and ankle up, right? 2 different ways of doing it, same accomplishing goal there. All right, anything you guys want to talk about specifically in Bontrager before we move on to this pathology, internal devices and some patho? Are you guys okay on body landmarks? All right, what's the jugular notch equal to? T7, good. Do you know the xiphoid tip, xiphoid process?
Yeah.
What is it equal to? T10, good. Do you guys know your ACEs, your crest? Are we good with body landmarks? I think I'm tracking okay. Okay. And then vertebral prominence is at the level of what? C7, good. And CR for chest x-rays are? T7, good. CRs for chest x-rays, T7. Depends on if you are shooting AP or lateral or PA or lateral, where you slice the mid-sagittal plane versus the mid-coronal for a lateral. All right, I think you guys are tracking pretty good. Let's get into some pathology. So we're gonna start on page 40 with internal devices. We're gonna start out with an ET tube. This is used to maintain the airway. It doesn't really tell you what it's used for, but it's used for maintaining the airway to support in breathing. So you don't need to know where the placement is. You don't need to know what happens if it's not in place. You need to know that we're probably going to take a chest x-ray to confirm the placement for sure. And if you want to know anything about it, where it talks about the tracheal bifurcation, you can know that the tip ideally should be approximately 5 to 7 centimeters above the carina. So where is the carina? What is the carina? The bifurcation of the trachea, the carina, the bifurcation of the trachea. So where the trachea splits into the left and the right bronchus. Really, that's all we need to know for the ET tube placement. It gives you a position, an actual x-ray, figure 3.3 of an ET tube properly placed. It's gonna be the one more central because it's advancing through the trachea. So endotracheal tube, so in the trachea. But used for maintaining an airway, sometimes used in surgery. If you've ever been put under for anesthesia, you've had an ET tube placed. If you are getting ready to go on a ventilator, you'll have an ET tube placed prophylactically. Let's talk about CVCs, or central venous catheters. So these are probably gonna be your main common ones here for line placements. They're inserted into the subclavian vein or more peripheral vein. If it's inserted into the peripheral, it is called a what? Does anybody know? If you use the peripheral vein instead of the subclavian? PICC line, good. It's a PICC line. So it's demonstrated on the next page, page 41, figure 3.6. That's a PICC line. So a peripherally inserted central catheter is classified as a CVC. So it's just kind of like a subcategory. But it's used for the measurement of the central venous pressure. So it's used for the measurement of the central venous pressure. PICC lines are really common for treatment for chemo or anything that needs to be administered very quickly.
Like a port.
Yep, similar to a port, yep, exactly. Very similar to a port. PICC lines go directly into the heart so that the medicine is able to advance quickly, travel through your body, you're able to feel better quickly. They do PICC lines on patients who have a hard time getting a stick for an IV, or if they need any kind of a long-term venous access. So instead of sticking somebody every day over and over again, they might have a PICC line. I'm sure you'll see it. Baptist has a PICC line team that comes up. If you've ever taken any post-op images after they place the line, they might have you come in, take a chest x-ray, they'll look at the placement. If they need to adjust it, they'll pull it in or push it in some more, pull it out or push it in deeper, whichever way they need to go, and then have you follow up and take another image. You don't need to know if these are placed correctly. Sometimes these will coil up and go into the shoulder on your image. So if you see it going from the subclavian or from the peripheral artery and it's kind of going over to the other side, it's obviously not placed correctly. So you should see it inserting right into the heart. However, it's not our call to re-expose the patient. We'll need another order if we are following up and doing another image, and it is going to be the physician's responsibility for ordering it. So just because it's placed incorrectly, you can't just take another picture. You have to have another order, technically. And then let's talk about the Swan's-Ganz. So the Swan's-Ganz catheter. Again, it doesn't really tell you exactly what it is. It tells you that it's used for measuring pulmonary wedge pressure, the capillary pressure. But basically it inserts into the right side of the heart and it monitors the blood flow and the pressure. So you're gonna see a Swan's-Ganz in the heart on the right side to monitor the pressure of the heart and the blood flow. Just to kind of break it down. Again, I would not read this chapter in detail because this is a lot of information and you're not expected to know any of this really. Just tiny bits here. The next page, page 42, it talks about a transvenous cardiac pacemaker. It's just a typical pacemaker. I'm sure you have all taken some kind of chest x-ray with a pacemaker before. Remember, we can x-ray somebody with a pacemaker, but usually they can't go into MRI unless the person who developed the actual pacemaker is there to stop it and start it again. So they are able to temporarily do that. Back in the day, they weren't able, they were ferromagnetic, so they weren't able to go into an MRI unit at all. But because pacemakers are so common now, they have developed them to be safe to go in there as long as we have somebody there to actually stop the pacemaker and then restart it. Because the actual contents could be skewed by the magnet moving and repulsing. So you don't want them to code on your table in MRI. But it's nice that they can actually have an MRI now. Okay, and let's get into some pathology. So I'm gonna skim through this hardcore. If you want to go back after class and kind of make yourself a study guide, I would use this specifically for the chest pathologies. These are the only ones that I have seen on any kind of a mock registry, prep, or a tech boot camp. So I would definitely focus in on these. We're gonna talk about a couple more of them in the book, common ones that you might hear or diagnoses that you might see, but definitely focus on these. You wanna know if they're additive or destructive, and you wanna know what they are. Some of these are kind of tricky though, because the amount of additive or destructive is so minimally, we're not gonna increase or decrease our technique. If we increase or decrease our technique, which one should we start with? KPP or MAS for additive and destructive diseases?
Additive mass, this question.
MAS or KVP? KVP. KVP. So if we add or destruct based on the disease, we are going to modify the KVP because KVP controls penetration, right? So not the actual quantity, but the quality of the beam. We would increase or decrease our KVP, so that's where we start. I'm sure you've worked with somebody who goes up or down on the mass on every patient. But we know that mass directly affects dose, so we want to focus mostly on the KVP these days. Of course, your KVP controls your contrast overall, so we have to be careful and make sure that we can still see the image, but KVP is going to be our standard for this. So let's start out with cystic fibrosis. So really, the only thing you need to know about this is the first sentence. It says it's a hereditary disease characterized by the secretion of excessively viscous mucus by all of the exocrine glands. So cystic fibrosis, the person is born with it. It says 90% of the morbidity and mortality related to it involves respiratory involvement. It used to kind of be a death sentence, but they're coming out with more and more treatments that are very effective these days. I actually know somebody who's like 35 now that has cystic fibrosis, so CF. And there's even more development to where they can say they can reverse it completely. A lot of times, characteristically, looking at these people, they're very thin. They can kind of go into depressive states because they can't gain weight, and they have a barrel or a long chest. So they'll have like a very wide open chest here, whereas ours are more flat. Theirs will be super round because of their lungs. They almost develop emphysema and struggle to breathe because of the secretions. And they're always coughing up stuff. So it's not like a dry disease or some kind of pathology that just prevents breathing, but it releases mucus. So it's kind of like they're always sick if they're not being treated for it. Forbiddance of treatment or refusal of treatment is normally going to result in death because this would cause you to have pneumonia almost all the time and you won't feel like you can breathe. We don't need to know the characteristics of this or how it appears on x-ray, so really I would just focus on the first sentence of that one. The second one here is hyaline membrane disease on page 44. Hyaline membrane disease. It's also known as IRDS, so I would know that. It's an idiopathic respiratory distress syndrome, and it's one of the most common causes of respiratory distress in a newborn. So this one is specific to babies. So if you had a baby early or you know somebody who has had a baby early, it's because they have a lack of surfactant. So surfactant, that blue word in there. So you wanna know that it consists of a mixture of lipids, proteins, carbohydrates, and creates high surface tension. So because they have a lack of surfactant, their lungs stick together and they can't breathe. Happens a lot in premature babies. You can see folds somewhat in the image in figure 312 on page 44. The folds are kind of vertical, and again, that's just the lungs when they're trying to breathe, they're sticking together because they have a lack of that surfactant that's actually been developed because they're preterm, not full term. Another one we want to talk about is croup. Croup is common. Anybody ever did a croup patient? No? Anybody's kids ever had croup? Probably. It's yucky. It's yucky. So it's a viral infection in young children that produces inflammatory obstructive swelling, localized to the subglottic portion of the trachea. So the picture here is a really good demonstration of exactly what croup does. 45, figure 3.13. So B, the one on the right, is a normal air-filled trachea. If a person has croup, it narrows the airway. So it creates a very specific barking type cough, easily distinguish if you take your kid to the doctor and they are in fear of croup. If they cough, they'll know if they have it or not. They treat it with normal antibiotics because it is a cold, even though croup specifically is viral. You can treat that with steroids. So they'll give the child steroid or some kind of inhaler to treat it. Your airway will never truly close from croup, but it can be very uncomfortable and feel like you're struggling to breathe because it is narrowed. So the steroid really helps open it up. So let's talk about inflammatory disorders of the lower respiratory system. We want to know pneumonia. That's a big one. So pneumonia. Acute pneumonia is an inflammation of the lungs that can be caused by a variety of organisms, most commonly bacteria and viruses. Regardless of the cause, pneumonias tend to produce one of three basic radiographic patterns. So it talks about the difference between alveolar or sac versus broncho or interstitial. It also brings in aspiration pneumonia. We really want to know that it's an inflammation of the lungs. You can develop pneumonia from bacteria, from viruses, or from aspirations. So from aspirations. So if you have somebody who is a stroke patient, they recently suffered from a stroke, they're not able to eat and drink properly, but they have pneumonia like every other week or every few days, every couple months, it's just a reoccurrence. They're probably aspirating what they're drinking and it's creating a pneumonia. So if you aspirate anything into your lungs, aside from air, bless you, you are exposing yourself to bacteria because it's obviously external and it could create an inflammation. Your lungs are fighting it. So that's all I want you to know about pneumonia. Don't need to know the radiographic appearance. Don't need to know specifically what interstitial pneumonia is, bronchopneumonia, or alveolar or sac pneumonia. Let's see, let's pass through that one. All right, let's go to page 49 and talk about TB or tuberculosis. So this used to be one of the only diseases that we would wear an N95 or a duckbill mask for to prevent because it's airborne. The droplets are suspended in the air. This one is classified as a rod-shaped bacterium with a protective waxy coat that permits it to live outside the body for a long time. So if you could think about it, think of like little Mike and Ike's. That's what I like to visualize for TB externally, if we could see them with our eyes. They have a waxy coating. They're kind of long and cylindrical, and they suspend in the air. So because it's airborne, the droplets are just hanging out in the air, but they're really tiny. And they can live outside of the body, so they're able to function, breed, reproduce, and suspend into someone else's respiratory system. So anytime you are in question of a TB patient, you want to have an N95 on to protect yourself. There's kind of a little bit of an ethical discussion right now though, are we really protected because we're reusing the N95 mask? So hopefully when you guys are working, you will have access to as many as you would like, or you could purchase some. Did I tell you guys to purchase N95s as well? Okay, so I have a few upstairs. I think I have 30 upstairs left, but the college is not buying anymore. So if you want one or you need one, come see me up there after class and I'll give you one so you can take it. But other than that, you have to order your replacements. If you order one and you want me to mask fit test you with your new one, feel free to bring it in and I can test you, just to see if you have full coverage and you're sealed. Do you guys have sized ones, or you just have the ones that he gave you before the universals?
We have one.
We use the ones at the hospital.
Yeah, the
Okay.
hospital gives them.
Okay, good, great. So if the hospital lets you have them, wonderful. If they don't, if you're limited, purchase some because you will need some. I only have one for everybody left though.
Are the ones that you have upstairs, the one Grant gave you?
They're universals, yes.
The little circle
Yes.
ones?
Yep, they're universals. They are universals. Alright, so tuberculosis can be active or latent. So when you are exposed to it, the person has to have active TB. So they would be hacking up a lung, they would look like death, they'd be crunching over in the bed, they're in the ER, they might think they have COVID, they actually have TB. Well, what happens is once TB enters your body, it enters into a latency period. The reason why I know this is because I was exposed. So if you ever get exposed at a hospital or a place that you work at, they'll usually follow you up with testing and you won't ever get another PPD because it will always be positive because the bacteria is in your body then. At that point, you just have to kind of treat it with antibiotics to decrease the values of the numbers of the exposures in your body to where it could never potentially become active. If you don't do the treatment, mine was like 13 months of antibiotics. If you don't do the treatment, at some point in your life, you could have an active case of TB, which is where your antibodies have to kind of flock to something else. So say you're like 90 years old and you have the flu and your antibodies need to rush over and protect you from the flu. They leave your TB, then they go up there and then your TB is active, like activated, right? So if you're latent and you have no symptoms, you can't spread it. It just lives in your body. So latent TB just lives in your body, you can't share it. Active TB, you can give it to somebody, you can pass it, very, very contagious, airborne, droplets suspended in the air. They are able to live externally outside the body for a long time.
When you have it, how do they treat it?
Active?
Yeah.
Just with the same antibiotics.
Oh.
Yeah, but you feel like you're dying.
Did you know you had it?
No, I didn't know that I had it. I didn't know I was exposed to it. When I went in for my annual PPD, it was positive. So they did it again, and then it was positive again. So then they did the blood draw, positive, and then they treated me. Yep. Yeah. Let's go to pulmonary mycosis. So pulmonary mycosis, it's on page 52. This is really the only fungal infection of the lung that we're going to talk about, so that's how you can distinguish it. It's a fungal infection of the lung. It tells you that it's most common in Mississippi River and Ohio River valleys, but really all that you need to know, we don't need to know the actual individual ones, the hispoplasmosis and the chondromycosis. We just need to know that it is an infection, a fungal infection of the lungs. Fungal infection of the lungs, pulmonary mycosis. You would,
Something in the water that like gives you?
it can be in the water, yes. Yeah, it can definitely be in the water, or the soil. So some kind of fungus that gets in you, and how it's gonna appear radiographically is some kind of like spore, like a mass. But they would have to actually go in and sample it to see if it's a fungus or not. Yeah, not a common one that we see.
look like this image?
That is a histoplasmosis, so that's calcification. So the bottom one is if it calcifies, so if it's been in your lung for a long time, but the top one is more accurate of what it would appear as like in an ER or something. So just one individual mass. And they're gonna sample it and actually test it to see if it's a fungal infection. All right, let's talk about RSV. So RSV is a really common one that we deal with all the time. In pediatric patients, it is estimated to affect almost all children by the age of 2. let's talk about the actual appearance. Hold on one second. Okay, the virus attacks the lower respiratory tract and causes necrosis of the respiratory epithelium of the bronchi and bronchioles, which leads to bronchiolitis. So basically, the infection attacks the bronchial tubes, which it causes inflammation, which causes bronchial spasms, similar to asthma. But this is very easy to pass. Contagious. Very contagious. It can be progressive as well, yeah. So definitely if you have a child who's an infant, so 12 months and under, it can definitely be critical. They treat it with oxygen usually, maintaining the airway. Sometimes they have to trach these patients. Sometimes they have to put them on a ventilator to repair the lung damage. But basically the bronchioles are inflamed, creating a very similar flu-like asthma. Flu-like asthma that can be passed. We can test positive for RSV as adults, but it doesn't affect us as bad because our bronchial tubes are much larger. So inflammation, we have more room for. Children and babies don't have a lot of room in their tiny lungs, so when it inflames, it really blocks the airways and restricts it. Let's see. All right, talk about COPD on page 54. COPD. So COPD, it kind of pairs with emphysema and chronic bronchitis. Bronchitis is going to be associated with cigarette smoking, as is emphysema and typically COPD. So you guys know these patients that smoke have these huge lungs, right? Big lungs, because they're overexerting them. Not good to necessarily have body parts that are larger than the normal population because your tidal volume is the same as everybody else. So if I can only breathe in this much normally, that's the size that I want my lungs to be, to fill them up. Because if your lungs stretch out and they become longer or wider than you actually need them to be, you can't fill them up, so you feel like you can't breathe because your tidal volume is decreased based on the volume of the size of the lung. So chronic obstructive pulmonary disease, it includes several conditions in which obstructions of the airway lead to ineffective exchanges of gases. So basically, it makes the person not be able to breathe due to obstructions. Under COPD, you have bronchitis and emphysema. So those are subcategories of it. So you have chronic obstructive pulmonary disease, and you have bronchitis and emphysema. Bronchitis, inflammation, increased inflammation, leading to severe coughing, production of sputum. Sounds gross. And then emphysema, which is a crippling and debilitating condition in which obstructive and destructive changes in small airways lead to dramatic increase in the volume of the lungs. So emphysema patients, they're always like this. Because they're trying so hard to fill their lungs up because of the expansion of the lungs, but they just can't. You don't have enough air. We're not functioned and created to breathe that heavily. But these three, so COPD and then your two subcategories, bronchitis and emphysema, 90% of these patients are associated with cigarette smoking. So don't smoke, right? Most of your campuses are smoke-free anyway, so you probably wouldn't be able to. In addition to the increase in the volume of the lungs, when you have emphysema, it transforms the small sacs into large sacs in your lungs. So it transforms those small areolas or alveoli into large bullae. So you need to know that word, B-U-L-A-L-A-E, bullae. So it transforms the small walls in between the alveoli into large sacs. This is where the exchange of gas takes place. And because you don't have more air than anyone else, you aren't able to exchange within your lungs, so you don't feel like you can breathe.
And that's just for emphysema?
Just for emphysema, yep. That one is specific to emphysema. All right, let's turn the page and talk about asthma. Asthma. So it it says it's a very common disease in which widespread narrowing of the airways develops because of increased responsiveness of tracheal bronchial trees to various stimuli. So basically, it's a narrowing of the airways due to allergens. A narrowing of the airways due to allergens. Asthma is interesting. It can be outgrown. You can have it as a child. You can outgrow it. There's exercise-induced asthma because of the sweat particles in the air that can irritate your lungs. So basically, it's allergens, though, of some sort. Asthma is really common these days. It has an image of it and how it should appear. To me, it looks very similar to pleural effusion. Figure 3.39. I wouldn't be able to necessarily pick it up on a radiograph, but I could probably say this or this, but you won't be required to. But it leads to swelling of the membranes of the bronchus, which leads to severe narrowing. Again, in children, it can be deadly because they don't have a lot of room for expansion and inflammation. If you read about deaths from asthma, a lot of them end up having like an asthma attack and they'll vomit, and if you're laying flat, you could choke on your vomit. So that's a common death related to asthma, choking on your vomit. Okay, let's see what else. Let's get that. Okay, page 59, pneumoconiosis. Pneumoconiosis. So this is also known as occupational lung disease. Occupation meaning the job that someone is doing. So there's three different types. And it's due to prolonged occupational exposures to certain irritating particles. So depending on what the irritating particle is, that depends on how they name it. So all three of them are considered pneumoconiosis, but there are three subcategories. So the first one is silicosis. It's the most common and best known work-related lung disease. Normally it's from quartz dust, mining, foundry work, or sandblasting. So obviously you want to protect yourself if you're engaging in any of these activities, protect your lungs. Silicosis though, it's obviously from high concentrates of silicone in your lungs. So sandblasting, quartz dust, foundry work, mining, things like that. Things that you do for a living though, occupational. Asbestosis, anybody want to take a swing? Asbestos. So that's why it's so important that you protect yourself if you are demoing something or working on something in an older house. Usually prior to the 1980s, they used this before they knew that when you destroyed it, it could get into your lungs and hurt you. Not super common anymore. And then the third one is anthracosis or coal workers pneumoconiosis. They have two names here, but obviously it is from coal mining, also known as the black lung disease because it has dark particles in the lung tissue. So think about the color of coal, right? It's dark. Page 65. You don't have to write this one down, but I just want you to know what it means in case you see it in a report. It says pulmonary metastases. So anytime you read mets in a report or metastases, or if it metastasizes, it is a secondary form of cancer. Okay? So it's not a primary. So if a doctor writes a report and says, I have metastasized cancer in my breast tissue, it's not my primary cancer. I probably have lung cancer or liver cancer. So metastases or mets or metastasizing is a secondary form of a cancer. Okay? Just want you to be familiar with it in case you read it on a report. Pulmonary embolism, page 68. We're rounding the corner. Pulmonary embolism. The only thing you need to know written somewhere within this is that it's a blood clot in your lungs. Okay? Pulmonary embolism, it's a blood clot in your lungs. The modality that we use to find embolisms is ultrasound, okay? So the ultrasound tech is going to come and scan a patient. Lots of times, if the patient is having like severe swelling in their leg, they'll do what's called a DVT scan to see if the person has a deep vein thrombosis, so a blood clot in their leg. If it is positive, they want to get the patient to the hospital ASAP to get that blood clot taken care of because it can move into your heart or your lungs. So if it's in your heart or your lungs, I'm sorry, your heart or your brain. So if it is in your heart, you can have a stroke. If it's in your brain, you can have a stroke. If it's in your lungs, you can have a pulmonary embolism. Okay? Could definitely be deadly. Super serious condition. All right, atelectasis on page 72. Atelectasis. So it's a condition in which there is a diminished air within the lung associated with reduced lung volume. What you want to know about this one is that it is most commonly associated with foreign bodies. So foreign bodies, common in children. Think about like M&Ms or Skittles or something that kind of goes into the lung cavity for some reason. Once they remove it, it will resolve. But it could place a restriction on the lung capacity and reduce the lung volume, struggling to breathe. All right, almost there, guys. 76, we're gonna talk about pneumothorax. Tell me what it is. You probably know this one.
Air in the
Or air in the pleural cavities, right? Air in the pleural cavity or cavities, which results in either a partial or a complete collapse of the lung. So the image appearance for this one, you definitely want to know, because this is a vital one. If you x-ray somebody in an outpatient center and you see this, you want to hold them there until the radiologist can look at the image, because they could die. They have a collapsed lung. So the imaging appearance, you want to know that all pulmonary markings are absent. So all pulmonary markings are absent. Does everybody know what that means? So the kind of striations that you would see normally. Let me pull up an image. Watch, demonstrate it just in case. So all lung markings being absent. That's a good one. So the pulmonary markings are kind of the small gray striations in the lungs. They're normal. You should see them. If you don't see them and your patient looks more like this person on the right, see how there's striations over here, kind of tiny vessels. Those are your bronchial tubes, your alveoli that are taking the exchange of air into your lungs. Over here, it's completely black. That's because this lung is collapsed.
The patient would be in distress from that, right?
They would, but I have seen a walkie-talkie patient who had a collapsed lung.
Okay.
Yeah. Yep. It was a person who struggled to breathe kind of always. She had emphysema. She was an older lady. She walked in, she had a cane, she had oxygen, and when I x-rayed her, I saw this, so. But normal patients, yes, are gonna be in distress. Again, here's a good one as well. So this one over here, see all these striations and kind of tiny streaks? This is normal for a lung. This is what it should look like to exchange the air. When you see something like this, there is no lung inflated here. Because there is air in the pleural cavity, it has deflated the lung completely. So they'll have to go in and pump it back up, right, and fix it. Everybody tracking? Everybody good with pneumothorax? pleural effusion. So effusion means fluid. So the accumulation of fluid in the pleural space is a non-specific finding that may be caused by a wide variety of pathological processes. The most common cause you want to know is the first one, which is congestive heart failure. Congestive heart failure. So if somebody has CHF, they will probably have pleural effusion. Congestive heart failure causes increased fluid around the heart, which will cause somewhat of a fluid increase in your lungs because they're close neighboring organs. Again, at the image appearance, the very first sentence tells you the earliest radiographic finding in pleural effusion is blunting of the normally sharp angle between the diaphragm and the rib cage, also known as the claustrophrenic angle. So I would definitely know that for pleural effusion. How to recognize that it's pleural effusion? The doling of the angle. I think that's it. Hold on. All right, that's all the pathology terms that we're gonna go over. I know, right? That's enough. All right, so let's talk about the difference between additive and destructive specifically. So if you are increasing air into the body somewhere, it would be additive or destructive? Air. Air. Think about how light it is. Destructive. Air. Air as opposed to tissue. Not necessarily specific to the respiratory system, but if you have air where tissue should be, it is going to be destructive. Okay? Kind of overall synopsis. For a pneumothorax, you're not going to change your technique. You're not going to know that the person has a pneumothorax until you x-ray them. So you wouldn't be able to change your technique. But because we're replacing air in the actual lung to air in the pleural cavity, we're not going to make a change in technique anyways. However, when we get into some of the other pathologies like pleural effusion, if your patient has a ton of pleural effusion and we're adding fluid, we're going to increase our technique. So anything with fluid or mass type structures, we want to increase the technique. So fluid or adding mass type structures. Fluid or mass type structures. For these specifically, there's nothing I can think of that you would actually make a technique change clinically. But as far as book and testing, anytime we add fluid, some kind of nodule or mass type structure, we up our technique to penetrate further. If we have air where there normally is tissue, we decrease. There's one on here that's not in the book. It's a hemothorax. Do you guys know what that is? Blood in the lungs. Hemothorax. Blood in the lungs. So it says hemothorax or pneumothorax. So pneumothorax, air in the pleural cavity. Hemothorax is going to be blood in the pleural cavity, right? So usually happens by some form of injury, trauma type patient. I have seen a question on that though. So that's why I pulled that one on here.
If you're going like to an inpatient's room and you know you're checking for line placement, would you bump up your technique so that they can see like the line more clear, like the direction of like where it's going?
Good question. So do you need to change your technique for a line placement? No, because the line is so small. They have created it to be a very thin strip of metal that portrays on the x-ray, so you don't need increased penetration. Good question. If you know your patient has some kind of replacement or prosthesis, like a hip replacement, knee replacement, things like that, I'd probably bump up your technique, right? So we have more penetration to get through that metal. Yeah, I would. Yep. Questions? Things you guys want to talk about? I know we covered a lot of information today, so you're probably a little burnt right now. Crispy.
Was there a lot of questions about additive versus destructive on the board?
So additive or destructive for the respiratory system, no. But once we get into actual like extremities, like bursitis, osteoarthritis, osteoporosis, petrocious passage disease, yes. So specifically for the respiratory system, I wouldn't focus on additive or destructive aside from pleural effusion. If you know that your patient has pleural effusion, you're probably gonna increase your technique to penetrate the fluid. That's one that I would focus on. Questions?
If you have an x-ray for possible foreign body, would you bump up the technique?
Ooh, depends on what it is.
Or if
So,
I have no idea, like the child?
if you have no idea, I wouldn't, no, because it's gonna be small if it's a baby. Now, if it is a light bulb or something like that in the booty, I mean, you've seen some weird stuff, right? It depends on what it is. If it's something metal in the rectal cavity, I probably would, if you know what it is. Usually you're not gonna know though, and I kind of associate like foreign bodies with pediatric patients and mental patients. So if you ever work at like a mental facility, you'll see a lot of foreign bodies like staples, paper clips, pins. They stick pins in their arms and stuff like that. So depending on the foreign body, the composition, the actual thickness of it, to be determined. But for a child, no, I wouldn't. Because it's probably something really small. Yeah, good question. All right, so I want you to digest on this material. Digest on it. We've got a couple of exams coming up in October, right? Great. All right, so I'll probably put a quiz on Canvas for pathology to give you a little bit of direction. It's only gonna be like 10 questions, but I'll try to have it uploaded tonight. It'll be due next Tuesday night, okay? And it will tell you on there when I upload it. You'll have to use smarter proctoring, so don't have your books out. I won't allow you to have anything in front of you. Only 10 questions though. Super easy, low pressure. I don't wanna stress you out. So I want you to digest this information. The goal is for you to learn it and retain it, not stress about it and try to overread. Stick to the material that we talked about for chapter 3 of this, okay? Don't get too deep in this. Even if you wanna go on and do more schooling, do it later, okay? Stick to your information that you need to pass your registry.
So this quiz is basically like chapter 3.
This quiz can be anything from chapter 1, 2, or 3.
Oh, okay.
Yeah, just a small little
In
recap.
pathology.
Pathology, yes. Yes, pathology. All right, so, make sure you bring your dosimeter next class. I need it, okay? Have a good day. Have a good day, guys.
When did you send the quiz with the detail?
Tuesday. Tuesday.
Unless it'll be my